Thank you for the introduction. I'd like to thank the meeting organizers for inviting me to present today and assigning me a topic for which there is very little data and even fewer answers. Here are my disclosures. The objectives of our morning's talk are to review recent data regarding the prevalence of chronic narcotic use in pediatric and adult patients with IBD, to discuss the risk factors for chronic narcotic use in IBD patients, and to explore the potential complications of chronic narcotic use. And I'll start with the sad truth that the US is estimated to use 80% of the world's opioids, despite having only 4.6% of the world's population. And since 1990, opioid use has increased by tenfold. As has been recently publicized by 60 Minutes, prescription narcotics often contribute to the illicit drug epidemic. And the story Heroin in the Heartland illustrates that it's not only histoplasmosis that is endemic in the heartland. So as you know, short-term narcotic use may be indicated in patients with IBD in the setting of an acute, potentially hospitalized flare or for postoperative pain management. Long-term narcotic analgesia is not recommended due to issues regarding tolerance and addiction, gastrointestinal side effects, infections such as pneumonia, we'll talk about that later, sleep disorders, and even a risk of mortality. From the Pediatric Ulcerative Colitis guidelines that Dan Turner and the ECCO group issued a couple years ago, quote, "Low-dose narcotics should be approached with caution and with close monitoring for complications in specialized centers. High or repeated doses should be avoided." We know from studies of adult patients that 66% of IBD patients who use prescription narcotics have evidence of narcotic misuse. In this abstract from last year's DDW, this was defined by greater than 2 dispensations by outside providers, in other words, doctor shopping. Chronic narcotic use is becoming increasingly recognized as a marker of and a contributor to IBD disease burden, and hence reducing chronic narcotic use is an opportunity to both improve care and outcomes. And indeed, the CCFA several years ago went through a prioritization exercise to identify the most important outcome measures for, in this case, adult patients with IBD. And as you can see, the proportion of patients currently taking narcotics was on the top 10 list from this prioritization process. So how often are our patients receiving chronic narcotic use? I always turn to our neighbors up north in Manitoba for the best population-based data. Recently, that group published that 5 to 8% of IBD patients are using chronic narcotics at any point in time, with a peak occurring right around the time of diagnosis. Seen graphically here, you can see that the top curves represent the proportion of patients at any point in time using narcotics as a function of time from diagnosis shown on the x-axis. Both Crohn's disease and ulcerative colitis patients are using narcotics much more frequently than population-matched controls. What about in the United States? So our group looked at a national U.S. claims database. We estimated the prevalence of chronic narcotic use defined by 3 or more outpatient dispensings over a 2-year period, and observed that 20% of adult patients are chronic narcotic users. And this is in keeping with a number of single-center IBD retrospective cohort studies. What about the prevalence of narcotic use in our pediatric patients? This study that I'm going to explain to you was published earlier this year in CGH by Jessie Buckley, who is a PhD student in our group. She used a large health insurance claims database called TruVin Market Scan, which comprises the claims data from over 100 employer-sponsored and private health plans. The study population that she was interested in included children less than 18 years of age with continuous enrollment over a 2-year period in 2010 and 2011. IBD patients were identified using a standard administrative definition based on ICD-9 diagnosis codes and IBD medication dispensings. In this analysis, she excluded patients who had undergone GI surgery. Chronic narcotic use was defined as greater than or equal to 3 filled outpatient prescriptions, and she analyzed not only the prevalence of this, but also the impact of covariates, including age, gender, region, healthcare utilization, IBD medications, psychological comorbidities and psychological medications, and select medical comorbidities for which narcotic use is expected and common. She found that 5.6% of children with IBD met this definition for chronic narcotic use. Chronic narcotic use was 2.6-fold higher in the IBD patient population compared to the general population, and greater than 6-fold higher in IBD patients with comorbid psychological impairment, defined by diagnoses of either anxiety or depression or the use of psychoactive medications, including the antidepressants that Dr. Busfaros just prescribed. So what are the risk factors for chronic narcotic use in IBD patients? This is a summary of the major adult studies that evaluated putative risk factors that lead to chronic narcotic use. Each of the risk factors are shown in the left-hand column. Different studies evaluated different factors and used slightly different methods, but you can see here that female gender, having diagnoses of pain, disease activity, smoking, polypharmacy, psychological comorbidity were the major factors that predisposed to chronic narcotic use. And I think the ones that were most consistent across studies are increasing levels of disease activity, smoking, and psychological comorbidity. I do want to call attention to IBD-IBS overlap as well. This was studied in only one inpatient study by my colleague Millie Long. All inpatient chronic narcotic users in our single center experience had evidence of IBD-IBS overlap, and so therefore it was impossible to estimate a relative risk because it was infinity. But I think this is a really important risk factor that we all need to be even more aware of. What about in pediatric patients? These are the risk factors that we observed in our study. Teenagers were much more likely to be chronic narcotic users compared to lower children. And in fact, in the age 15 to 18 group, chronic narcotic use approached the 20% rate that we observed in adults. Having a non-IBD comorbidity like fracture expectedly is a risk factor for narcotic use. Psychological impairment, hospitalization, and other markers of disease severity, and inpatient and outpatient utilization, as well as polypharmacy. And again, you can see that these themes were very similar to themes observed in adult literature over the last 2 decades. Finally, what are the potential complications of chronic narcotic use? And I'll start with a caveat emptor, let the buyer beware. Really, are negative outcomes a consequence of narcotic use or underlying IBD or the extraintestinal complications of IBD itself? From Dan Turner's ECCO guidelines, quote, narcotic use may be a marker of more severe disease rather than a predisposing factor for, in this case, toxic megacolon, but I think you can fill in any one of a number of possible, quote, consequences of narcotic use. But nevertheless, I'm going to review the recent literature on a couple of notable and recently described consequences. I'll start with a few abstracts presented at DDW this year. This was a study done by Eva Zigathy's group that was a prospective observational study of consecutive adult patients seen in a tertiary IBD clinic. Patients were screened for depression and suicidality using the PHQ-9, and narcotic use was an independent predictor of suicidality even after adjusting for depressive severity and SSRI use, IBD disease activity, and IBD-specific quality of life, lifetime surgery, and again, SSRI use. Here's another abstract from DDW, which was a retrospective chart review of Crohn's disease patients undergoing either temporary or permanent ostomy placement. And as you can see, narcotic use prior to admission was the most significant risk factor for postoperative serious adverse events, including infections and surgical complications. What about sleep? This is something that Dr. Busvaros alluded to earlier. Me and my colleagues at UNC maintain the CCFA Partners Internet-based Cohort of children and adults with inflammatory bowel disease. This was a study done by Ashwin Ananthakrishnan at MGH based on the adult cohort study. He used a random sample of participants who completed an NIH PROMIS survey of sleep disturbance with a sample size of over 3,000 participants, and factors associated with sleep disturbance were evaluated using multivariate logistic regression. These were the major predictors of sleep disturbance, and as you can see, narcotic use was associated with a risk of about twofold. And of course, it's hard to kind of figure out what comes first, and this may be a self-perpetuating cycle, as sleep disturbance may influence pain perception, which then may influence chronic narcotic use and sleep disturbance, so it kind of can go around and around. What about serious infection and mortality? I'll refer you back to the TREAT registry and the first published data from 2006. This was a study led by Gary Lichtenstein with over 6,000 adult Crohn's disease patients from 212 centers in the TREAT registry, Narcotic use was a predictor of serious infection in both adjusted and unadjusted analyses with a adjusted odds ratio of 2.4, and narcotic use was a predictor of mortality in unadjusted analyses only with an odds ratio of 1.8, although there was a non-significant trend in the adjusted analyses. What else about mortality? Again, this is recent data from the Manitoba population-based IBD registry. 406 IBD patients experiencing non-cancer deaths were matched to 2,054 living patients, and heavy opioid use was strongly predictive of mortality, again with a adjusted odds ratio in the 2 to 3 range. Finally, I'll remind all of you about narcotic bowel syndrome, which is a progressive syndrome of chronic pain in patients treated with narcotics. Pain paradoxically worsens or only is partially responsive to escalating doses of narcotics. Pain also worsens upon narcotic weaning, and so as providers, we're often caught between a rock and a hard place, and treatment alternatives therefore involve not only a narcotic taper, but also careful attention to psychosocial needs and psychopharmacological interventions. So in summary, chronic narcotic use occurs in about 5% of children with IBD, is higher amongst teens, and is almost threefold higher than in the general pediatric population. Risk factors, at least based on pediatric and adult literature to date, appear to include disease severity and symptoms, psychological comorbidity, and IBD-IBS overlap. And I think there are multiple negative health consequences that have been reportedly associated with chronic narcotic use, although evidence of causation is tenuous at best. Here are my take-home clinical points. First and foremost, we're all here to optimize the medical and surgical management of IBD and its complications. That's why we took our time to come to this meeting. I think it's always important to recognize and treat non-IBD causes of pain in our IBD patients, things like bacterial overgrowth, things like IBD-IBS overlap, and even be on the lookout for medication toxicity, whether it's due to iron, whether it's a pancreatitis associated with thiopurines. But not all pain is IBD, and not all pain requires narcotic use. And I think, as Dr. Busvaros mentioned earlier, we really do need to recognize and treat anxiety, depression, and other psychological comorbidities. And so stay tuned, because Eva Zigathy is up next.